the definition of scoliosis needs to be updated. Because right now, the definition of scoliosis really just pertains to the curve. The curve has to be 10 or more degrees, and there has to be a rotational component. Well, really, the problem with that is that it really sort of discourages any investigation into underlying reasons as to why that curve is there in the first place. And so everybody gets really caught up into just treating the curve for treating the curve's sake. When in reality, that curve is not really representative of the whole condition. It's actually really just the main musculoskeletal symptom of the condition.
Welcome to Personalized by VitaminLab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Duizer. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome back to Personalized. I'm your host, Dr. David Duizer, and today we're sitting down with someone who fundamentally changed how we think about scoliosis treatment by asking a deceptively simple question. What if we're treating the wrong thing? Dr. Mark Morningstar didn't set out to become the father of comprehensive scoliosis management. He set out to find a better way, one that prioritized the condition over the curve, one that kept kids being kids rather than patients waiting for the inevitable. With a Doctor of Chiropractic from Palmer College, a PhD in Health Services Management, and 3 board certifications spanning nutrition, spine care, and integrative medicine, Dr. Morningstar brought an unusual lens to a field that had remained largely unchanged for nearly a century. 60 peer-reviewed research articles, patented exercises and equipment, and thousands of patients whose trajectories changed because someone dared to look beyond braces and surgery. The ScoliSmart approach he pioneered uses DNA and clinical testing to identify and address the root causes of idiopathic scoliosis, not just manage its symptoms. It's work that's given families around the world something precious, options they didn't know existed. This conversation goes deep into why comprehensive care matters, what the science actually tells us, and how we can think differently about conditions that seem structurally simple but are functionally complex. Please enjoy our episode with Dr. Mark Morningstar. Welcome back to Personalized by VitaminLab. I'm your host, Dr. David Duizer, and today I'm speaking with Dr. Mark Morningstar. How are you doing today, Mark?
Thank you for having me on.
I'm so glad to meet you, to have a longer chat with you. We've already met, but I've got some really curious questions for you today because I'm really interested in your approach to scoliosis care. But before we get to that, can you tell me a little bit about, and this is for all the people who are niching in their practice, I'd love to hear about how your career got to this point and your focus dialed in on this one very important condition.
Well, like I always tell everybody, I wish I had some really cool personal story like, I have scoliosis or something like that. But the reality is, going all the way back to my training in chiropractic school, I was always somebody who had a very high rehabilitation, active care kind of a mindset. And, when I graduated, came out in the real world, opened my practice up, one of the big challenges has been to get patients to follow through on home care recommendations. And that's true for any specialty, frankly. But, as a chiropractor, I always felt like very early on that most of what I was treating were problems that I was associating with essentially poor lifestyle decisions. So, of course, logically, one of the big fixes for those things is we need to make the following changes at home. And we need to implement the following exercises to, complement what I'm doing here in the clinic so that eventually you don't always need to have a codependent relationship on me and that you can, do this on your own. And the analogy I always use with everybody is, look, the reason why everybody only goes to the dentist twice a year is because they brush their teeth at home every day or are supposed to. And if I can teach you how to do little things like brush your teeth for your back that you can do on a day-to-day basis, well, then you shouldn't have to come and see me every week or every month or what have you. But of course, even at that point, it was like swimming upstream, getting people to do a lot of exercise stuff. Essentially to the point where I kind of almost quit practice because I'm like, look, if, it's sort of like having this perpetual ethical dilemma to where it's like, look, I know what the solution is for these people, but yet they still rather would just come to me as a Band-Aid.
Mm.
And to me, it's just sort of, what am I really doing for these people at that point? You know what I mean? It's like, so you could replace me with a bottle of Motrin. I mean, to be
Right.
perfectly honest, for what you're using me for. So, however, something started happening at the same time is that I practice in an area where the closest orthopedic surgeon is about an hour to a little over maybe 75 minutes away. So I started having patients whose children were now being diagnosed at a normal pediatric well child visit with scoliosis. And maybe they're in a situation where they're on they're not going to be able to see the orthopedic surgeon for a few weeks or several months, up sometimes. Or maybe they went to see the orthopedic surgeon and the surgeon said, well, we're not really going to do anything because it's not bad enough. Or all the way at the other end of the spectrum, they're already being told, well, you know what, your child is should have scoliosis surgery, and let's get that scheduled. And of course, this is all hitting the parents for the first time. Well, what flipped the switch for me personally was that although maybe mom and dad did absolutely nothing of what I asked them to do at home, they were going to be 100% certain that their child was going to do whatever I instructed them to do at home in order to avoid a more invasive treatment. And of course, with the home compliance came predictable and consistent results in their outcomes. And so naturally, it just kind of rejuvenated myself personally, to the point is, you know what? Being that most parents are going to make their kids do the stuff and they have somebody, make keeping them accountable at home, it makes my job a lot more fun. And frankly, scoliosis is a condition that a child didn't ask for as a result of bad lifestyle choices.
Mm.
This is something out of their control in large part, and a lot of it is genomically based. And so it became much more rewarding to help children who are, really a victim of their circumstance in that regard.
Can you give me some examples? Like what was the rewarding part? What kind of transformations did you see?
Well, so as an example, when you look at a lot of kids who maybe were told, well, the only thing we can really offer you is to wear a 23-hour a day rigid brace.
Hmm.
Well, first and foremost, there aren't a whole lot of kids out there who really enjoy doing that. And frankly, when you look at a lot of the literature on bracing, the compliance with recommended brace wear times is very, very poor historically. And honestly, when you really look at scoliosis treatment, the best treatments are the ones that people will actually do
Mm.
when you really boil it down. So a lot of the stuff that we require them to do instead from an active care exercise perspective now only requires them to maybe put in an hour a day, not 23 hours a day.
Mm.
And so we're able to have a lot of kids avoid a brace at all. And maybe for the kids who do need one, maybe they're only sleeping in a brace, which now avoids a lot of, I don't have to wear it to school. It's not going to interfere with my extracurricular activities and so forth. But I still retain a lot of the benefits of the brace at nighttime, which is sort of like what they call the guided growth concept, because obviously most of their active growth is going to occur at nighttime while they're sleeping. And so why not wear a brace during that time? Because now they're not, we don't have to really worry about a deconditioning component because they're not upright against gravity when they're sleeping. So we sort of eliminate some of the drawbacks of daytime full-time bracing, and yet we retain the benefits of the nighttime bracing. So it's a lot easier way to get kids to stay compliant with the treatment, especially when they have to maybe do it for a lot of years. If it's say a 10-year-old coming in, conceivably they're going to be after doing this stuff for maybe the next 4, 5, 6 years. And if we can make it such that they can build it into the routine and make it a consistent habit, well, then the benefits are more likely to not just be consistent, but also to be amplified.
Oh yeah, completely.
Or on the other end of the spectrum, you get kids coming in who are, approaching a surgery threshold, or maybe they're already there, into 50 degrees or up on their curve measurement, and they're being told that they need to have surgery. The nice thing is we're able to get a lot of kids under that surgery threshold and spare them from the surgery, at least, while they're still growing. And then again, they're sort of also empowered to keep going with that routine, even once they hit skeletal maturity, because again, scoliosis, like most health issues, is a dynamic problem. It's either only getting better depending on what you're doing about it or getting worse depending on how you're neglecting it. So we approach that no differently than somebody, looks at any other chronic health issue.
So preventing or delaying surgery was also a huge win.
Absolutely. Absolutely.
I bet the kids are just thrilled. Like, of course, they don't have to go into surgery.
Right. Absolutely. Absolutely. And what's really cool is so of course I've been doing this long enough now. I have a cool there's a wall in our office here in the rehab area. where a lot of my scoliosis kids who end up going on to play college athletics of some type, we
Wow.
actually we've had them send us their college sports photo in their
Hmm.
college uniform and the whole thing. And we basically have like a wall of fame for all of our scoliosis kids.
Amazing.
And basically the caption on the wall of fame reads, you know, these kids didn't let scoliosis define them. And I mean, we have all levels. We have high jumpers, volleyball, basketball, golf. I mean, it's pretty awesome.
Oh, that's so cool. Yeah, I love that. That's an awesome idea. And I bet walking by that every day keeps you going too.
Right. Absolutely. Absolutely. And the kids come in because, it's hard, especially when you look at scoliosis from a conventional perspective. You know, a kid sees an x-ray, and even the parents to a large extent, they see the x-ray, the ortho puts it up or whoever puts it up, and you see this curve and it gets measured and everybody gets really stuck on that curve measurement because that's how the conventional management strategy is laid out. And so naturally people think, you look at this x-ray and people think this is like a wet noodle holding their body up.
Mm.
And they don't recognize that this curve is there because the brain put it there to make the best of a bad situation. And I can kind of detail that further. But anyhow, people instantly think, or children actually think, oh my gosh, I can't play sports anymore because look at my back and all this kind of thing. And, one of the first examples I always use with people is to say, and maybe some of this is a little bit of mental gymnastics, but maybe there's some truth to it. But, everybody at least sort of remembers Usain Bolt, for a long time was the fastest man on the planet. And he has a very significant scoliosis in his low back.
No way.
And not only did he not use that as an excuse, but he actually goes on to actually tell people, I think I am the fastest man because I had this scoliosis and it changed my gait and the way I run in such a way that it actually made me faster.
Wow.
So even if that's just sort of a mental gymnastics motivation kind of a thing, to
Sure.
use it not as a victim, but as, a superhero skill, if you will.
I have a superpower. That's right.
Right, right. You know what? That's what most kids need to hear right away. Is, you know what? You have this curve, so what? We're just going to make sure that it doesn't cause you a long-term problem.
VitaminLab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and VitaminLab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
We need to take these two stories. For the first story, for the practitioners watching, because these are great stories that I would love to be using in my practice. I'm going to start using them. I'm stealing them, by the way.
Have at it.
The first one is the dentist thing. That's genius. It's genius because I mean, I think back to I wrote a huge paper on public health promotion of exercise and how governments should be investing in the promotion of the benefits of physical fitness. And but no, I don't feel like in Canada here anyone's ever used that analogy. Like we're doing it for the dentists. We should do it for the ortho.
Absolutely.
That's smart. That's smart. And then the second one is this Usain Bolt story. I got to remember this. I think the superpower analogy is really, really effective for kids, but it can be effective for adults as well. Like, just getting people to talk to themselves in a positive way can be really helpful. Like, okay, this is good actually. That we can do something with this.
We can still make lemonade out of lemon, so to speak.
That's right. So
Yeah.
let's go through your approach. So I'm really interested in how you treat holistically. I know that you've said in your writing that scoliosis really isn't just about the curve, and you've kind of touched on it a little bit so far. But what does that actually mean for you when you assess a child when they first come to see you? How are you thinking holistically here?
Well, I think the first thing, and even in my own practice, what I hope people always walk away from when they meet me for the first time, or even if we're just doing a phone consult to see if they're a candidate for treatment, is the idea that the definition of scoliosis needs to be updated. Because right now the definition of scoliosis really just pertains to the curve. The curve has to be 10 or more degrees, and there has to be a rotational component. Well, The problem with that is that it really sort of discourages any investigation into underlying reasons as to why that curve is there in the first place. And so everybody gets really caught up into just treating the curve for treating the curve's sake. When in reality, that curve is not really representative of the whole condition. It's actually really just the main musculoskeletal symptom of the condition. No different than if you're just, it takes but a cursory review of PubMed to also see that, kids with idiopathic scoliosis are much more inclined to have low bone density compared to their peers. They're much more inclined to have low progesterone status compared to their peers. They have a much higher propensity for digestive problems, a much higher likelihood of emotional symptoms like anxiety and introversion and all of these kinds of things. And when you look at it that way, it at least allows you, especially for those of us who are more of a holistic or integrative kind of a mindset, to really expand your viewpoint and say, okay, if I want to at least prevent this curve from getting worse, it only makes sense that I have to try to address the underlying reasons as to why this curve is here in the first place. Now, everybody, again, admits, in the real world who, has a scoliosis predominant practice, that scoliosis either starts or rapidly progresses during times of rapid growth or hormone change. So you got puberty, pregnancy, and perimenopause. And obviously, if we know that hormone change and active growth are really some of the primary drivers, it only makes sense to find out what is it about that person and their hormone status and their growth status that's allowing this curve to take place, or more accurately, that's forcing the body to create this curve as an adaptive response to the underlying problems. And so we do a lot of that investigation. So most of our workup on scoliosis patients is really no different than a workup would be for somebody with high blood pressure. If I'm looking at it from a holistic perspective, it's just figuring out, okay, these are the things that we know. And really the frustrating part for me is that most of this information has been already published for the last, 40 years or so. It's just nobody really ever does anything about it because, again, it's usually an orthopedic surgeon that's spearheading the management of the condition. And these are things that they don't deal with in a day-to-day setting. So it's not really necessarily in their clinical wheelhouse, so to speak. So it's now scoliosis really probably most accurately is something that should be addressed by an endocrinologist, an orthopedist, a physiatrist, a gastroenterologist, and a geneticist. If you're really trying to, affect all facets of the problem.
Completely. That's so interesting. My goodness. Okay, I didn't know some of this literature. I don't know this research. I'm not familiar with this. So you see, for example, specific hormonal patterns that are suboptimal, you could say, or how what's the evaluation look like on the hormone side and the digestive side?
So I would say on the hormone side of things, as kind of interesting things that we know is that a lot of, in fact, this was published in 2023, I believe, where we showed that children, adolescent females with scoliosis, have about half of the progesterone, the salivary levels of progesterone, as their peers.
Wow.
And those levels, and when we follow those people, follow female patients with scoliosis through the lifespan, drawing on patients of all ages from our practice here, that the progesterone levels that are off in adolescents don't actually match up to the non-scoliosis population until post-menopause. So all the way through the lifespan, the progesterone's running low. Well, of course, most people have a good sense, especially from a reproductive health perspective, of what progesterone does. But what most people don't really appreciate is that in adolescence, one of progesterone's chief roles is the development of peak bone mass.
Wow.
And of course, that is also one of the key drivers of curve progression is abnormal bone mineralization. And you could go a step further and say asymmetric bone mineralization, because of course, bone mineralization has a neurochemical or neurohormonal component, and it has a biomechanical / gravitational component. And if I already have a small curve, I'm going to mineralize in areas that are under less compression faster than the side that has more compression. So it's just going to feed into curve progression if I have a bone mineralization problem due to a hormone deficit of some type. whether that's progesterone or melatonin, which obviously is involved in bone lengthening in adolescents. And most people don't really look at these hormones from a pure musculoskeletal perspective. It's just usually a brain/psychological perspective or a reproductive health perspective.
Very interesting. What about on the digestive side? What are some things that you see?
Digestive side. So, in fact, there's a PhD actually in Quebec right now, Alan Moreau, who is putting together. In fact, he just published a study design for this the end of last year, looking at the different the microbiome of scoliosis patients versus non-scoliosis patients. But we've noticed that actually for quite a while ourselves. When you have a distinct lack of commensal bacteria and probiotic bacteria in patients with scoliosis compared to those who don't. Now, whether that's cause or effect, really nobody knows. It's really just an associative kind of a factor at this point. But that's a really a big thing that we notice. And a lot of the investigations into digestive influences started actually with a lot of research into neurotransmitter problems in scoliosis patients.
How so?
So, for example, and again, going back into my practice, I'm in a multidisciplinary practice, and we do a lot of functional medicine here. Frankly, and everything I'm really talking about is functional medicine in that sense, just applied to a very specific patient population.
Mm-hmm.
So, a long time ago, I started doing urinary neurotransmitter testing in scoliosis patients and started noticing very distinct differences compared to my non-scoliosis patients or the other doctors in here and their non-scoliosis patients.
Mm-hmm.
And I actually reported some of this in an abstract presentation at SOSORT back in, I think it was 2012, somewhere in that range, in Chicago. And one of the key neurotransmitter differences was how low scoliosis patients were in their urinary levels of serotonin compared to peers.
Wow.
And of course, again, everybody knows what serotonin does from a brain perspective, but not few people really appreciate the fact that it controls 80% of all your peripheral nerve pathways. So if you don't have serotonin, you really don't get really good peripheral, especially as it involves the torso, muscular coordination and firing. And of course, serotonin in the brain is responsible for your brain's internal mapping of all of your, postural coordination and all your postural muscles. And so anyhow, long story short, I presented these findings, and there was a doctor who stood up over from Italy, and I'll never forget this forever. But he stood up because it was a Q&A thing afterwards. He says, "Well, Mark, he says, if all of these scoliosis patients have low serotonin, how come they're not all depressed?" And I sat there for a second, and it's just like, why didn't I think of that?
Mm.
And at the time, of course, the room kind of chuckled a little bit or whatever at the question. And I said, how do we know they're not? And about 4 years after that, a very big study came out of Poland where they were the first to show that, as a matter of fact, kids who have scoliosis compared to their peers score much lower on mental health questionnaires compared to their peers.
No way.
Not necessarily to the magnitude of what you would label as depression, but they were far more likely to be introverted, to withdraw from, social situations,
Mm-hmm.
and have anxiety.
Wow.
And it's just like, holy cow, he was onto something and he didn't even know it. And so that really only confirmed what I found. And multiple places have now since confirmed a lot of those mental health kinds of differences in scoliosis patients. And all I did was really report or test something that I noticed. But even that had already been reported by studies going back into the mid 1980s, where they were showing that melatonin and serotonin were off in patients who developed scoliosis.
Seriously.
But nobody really ever does anything about them. And that's the rub.
Wow. Wow. And now we'll get the microbiome info in support of our own production.
Right.
Naturopaths are going
Right.
to love this. This is great.
Exactly right.
Wow. Wow. Well, I can see how interesting this can be. Like so often when you're niching, people might look at your career and be like, okay, you do this one thing. You're actually doing
Right.
50 things for this one.
Right.
It's amazing.
Yeah, it's to the point where I feel like anybody who's treating a scoliosis patient, if you're not looking at all the functional medicine components of it, you're really missing 80% of the condition.
And we're talking about 99.9% of people who are treating scoliosis.
For sure. And I think that's where historically, so, some treatments get sort of a bad rap. Like, for example, take bracing, right? So bracing, unfortunately, I mean, the compliance thing is a separate issue, but let's assume that compliance was good
Just perfect.
across the board. You're still going to have a fairly high failure rate with it because you're not addressing the underlying reasons as to why the curve is there in the first place. And if I'm not doing that in a large sense, if I know that that curve is there because the body put it there as an adaptive response, by just wearing a brace and not addressing the underlying reasons as to why that adaptive response took place, I'm literally trying to go against what the body's trying to do. And so the body's not going to accept any kind of a change through a brace or any other external means if I don't get rid of those intrinsic factors that cause that response in the first place.
Right. Yeah, it makes total sense. Can we talk about the role of genetics and genetic assessment here? And can you give me some information about genetics in this condition?
So, again, for a long time, historically, as I think they do with many illnesses or disorders, is they try to find the one gene that is like the magic bullet or the fountain of youth for that condition.
Yeah.
And so again, kind of more in like the mid to late 90s, they really started investigating genetics of scoliosis more heavily. And pretty soon, all of a sudden, they came out with like a dozen or more genes that were all supposed to singularly cause scoliosis. Well, what you really find is that present day, there are a couple dozen genes that all have the ability to trigger scoliosis. If you just look at genome-wide association studies,
Mm-hmm.
and they have sort of abandoned the kind of one gene, as a causative agent, and sort of accept that it seems to be a multifactorial epigenetic problem, not a genetic, issue per se. So a lot of our genomic investigation is really focused more on saying, okay, if we know that, for example, take the progesterone issue or the bone density issue, well, there are inevitably going to be certain genes that signal for those functions to take place. So rather than looking at saying a gene is off, so I'm going to have this problem, I'm looking at saying, okay, I know that this patient has, for example, low vitamin D, which is a well-known thing in scoliosis patients. Well, if they have VDR receptor polymorphism as part of their problem, it's obviously going to make it harder for that person to retain normal vitamin D levels through natural sunlight exposure. So there are going to be other things that we have to do, and probably on a more long-term basis, if they have a genomic predisposition to that vitamin D deficiency versus just having a frank D deficiency because I don't have enough sun exposure, or I live in a northern climate, or I'm, pasty white, or, whatever the case may be. So it steers us into saying, when I'm working with a scoliosis patient, the genomic variants allow me to work from the most upstream aspect of those reasons as possible. That way I can implement a much more broader effect, and more importantly, almost implement sort of a preventive effect on those things long term. Because, as an example, the one that probably most everybody has heard of by now is the MTHFR gene variant. Even the general public really has at least has heard of that by and large. Well, that also pops up in scoliosis. And in fact, we published a paper with Jessica Wright, who is the lead on it. She is a pharmacogenomic pharmacist for the Mayo Clinic. And we published a paper showing how patients who had both the MTHFR gene variant and the COMT gene variant, their curves were actually far more likely to worsen by 20 degrees or more from initial diagnosis till end of growth, compared to scoliosis patients who had either one or the other, or they had neither. So a lot of this genomic predisposition helps us tackle, and it even helps us with a patient selection to a certain extent, insofar as saying, okay, I need to establish, like any practitioner should do, I need to try to establish realistic clinical outcomes for this particular patient.
Mm-hmm.
And those outcomes are going to be directly dependent on that person's genomic predisposition and how significant or insignificant that is.
Mm-hmm.
The problem is, over time, it has gotten sort of simplified into saying, well, I know that if, this child's mom had scoliosis, I know they have a bigger genetic risk compared to somebody else. Well, maybe they don't. And what we find is then that if we're looking at a whole series of different gene variants, rather than looking at maybe 3 or 4, we can take a genetic profile and say, okay, you have genes that influence your microbiome. You have genes that influence your neurotransmitter conversion. You have genes that influence hormone metabolism. You have genes that influence bone mineralization. If you have a number of these across the board, then I, as a practitioner, might sit down with the family and say, look, before we get started into this, there is a reasonable chance that your daughter is going to fail treatment, even if she's 100% compliant with what we ask her to do. Because she has such a huge genomic risk, I don't know if we're going to be able to overcome enough of that to reduce the chance of curve progression enough. We might, but I at least want that to be on your radar so that if it does worsen, it doesn't look like we did something wrong or we forgot something. It's just we knew that there was a chance of this happening right from the outset.
No, that makes sense. So is that why we should be looking at both DNA and downstream effects of the DNA, the nutrients and neurotransmitters and microbiome, just to have that?
Yeah, absolutely, 100%. Even in a different example, Ehlers-Danlos syndrome, right? Most people are aware of that, and most people are maybe not aware that not all forms of Ehlers-Danlos have distinct genetic origins. There are a couple of types of Ehlers-Danlos that actually are only noticeable when you look at epigenetic expression of certain genomic variants, not just not looking at it just as an autosomal dominant kind of a disorder. And so I think scoliosis is much the same way. It's one thing to have genetic predisposition, but until you verify that that genetic predisposition is starting to manifest downstream, now it becomes easier for me to say, okay, these are the things that we have to tackle because they are being epigenetically expressed, and we have to mitigate these to reduce the chance that whatever we're doing from a physical treatment perspective for the curve is going to be much more likely to succeed because we're getting rid of the underlying reasons as to why this happened.
That totally makes sense. I love that. And I bet it's so motivating for families and helps them so stick to the program once they see that, okay, this is in your genes. Plus we have tracking tools. Let's talk about nutrients actually and the actual tracking that you can be doing. So we've talked so far about maybe determining the need for vitamin D because of the receptor challenges. Same thing with methyl donation with MTHFR. But what are the tests you're doing for nutrients, and what are kind of the most common nutrients that you're seeing are needing to be supported in this population?
Well, some of the ones, again, kind of going back to what's been out there for a long time, it's been known that scoliosis patients are much more likely to be low in vitamin D3. They also tend to run low on their selenium levels, manganese levels. One of the things that we notice is that it's not necessarily from frank deficiency per se, but they tend to have a lot of reduced conversion or activation of a lot of their B vitamin cascade.
The conversion challenges.
Yep, absolutely. And then we also tend to run, again, knowing that so many scoliosis patients, especially the females, are low on their progesterone, we tend to then run upstream serum testing on pregnenolone and then also even on their vitamin A. And so there are a lot of times if we know that they're low on progesterone, because obviously if it's a young child, I don't necessarily want to put them on progesterone. That's not always a smart idea.
Mm-hmm.
But it's much better if I now know that, okay, well, their progesterone's low because they're low on their pregnenolone. Well, at least I can give them pregnenolone as an example. Or if maybe I want to work further upstream and find that vitamin A is also being compromised, or maybe it's at the low end of normal, something like that. Well, now I'm not getting my natural conversion into pregnenolone because I don't have the vitamin A enzyme there, acting as that cofactor. So, we can give them retinol palmitate, for example, and help increase that conversion. And so it's just really it's just taking nutrigenomics in that sense. And again, applying it very specifically to scoliosis patients.
Definitely. Do you have a specific group of nutrient tests that you do for each person?
You can. So some of it depends on if it's a child or adult, but if let's say it's an adolescent, I'm usually going to start with the non-invasive testing. So we almost always do genomic testing. Will you almost always do just to call it a neurohormone test, but it's all the urinary neurotransmitters plus basic saliva hormones, estradiol, testosterone, progesterone, DHEA. So, and a 4-part cortisol with that. Those are kind of the initial starting ones I do. And then I kind of plug that downstream information and compare that against what their genomic profile looks like to see, where we're going wrong. Do they have something wrong purely due to environmental issues, or is it genetically predisposed? And then that sort of dictates to me how we intervene for that particular patient.
Right.
For adult patients, I tend to usually more start in with the bone density side of things, only because most of the adult patients who come to see me are usually, 50 years old and up, to where either maybe they're already in perimenopause or maybe they've been postmenopause for a little while. And establishing whether or not they have a bone density issue is, to me, one of the very first important steps, because if they have an ongoing bone density problem or this ongoing demineralization process, if I don't make an effort to at least stop that process, no matter what I try to do to help their curve, it's going to sabotage the benefits of whatever we're doing to help the curve, because again, they're going to lose bone faster on the concave side of their curve. So it's just creating this feed forward loop with the curve measurement. And if I don't stop that, nothing I do is going to be able to help on a long-term basis. So we try to go to that extra step first of saying, okay, if you haven't had a bone density scan, it's probably a good idea to start with one. And then going on from there, if it does come back that you have low bone density, well, now I need to backtrack and figure out why. Is there a progesterone thing, or is there if your status, post menopause by this point, you're probably low on everything. And then I'm also checking their vitamin D3, probably also using K2, a little bit higher concentrations. So, we tackle that almost in many ways as the primary issue first. And then once we get all of that sort of figured out, now we're going back through and working through the curve itself.
Makes total sense. Love it. Absolutely. Okay. Let's go back to the kids. Because as a parent, now I've got a bunch of kids. Fortunately, at the current time, they don't have scoliosis, but this could seem very overwhelming.
Sure, sure.
If you were to call or watch this show and be like, okay, we're going to check all of these things. We're going to build this huge approach. As a parent coming in, what are the questions that I want to ask? What is the information that I need? Expectation setting, for example. Put yourself in the parent's shoes coming in who maybe feels a little bit overwhelmed. I had some notes here about some questions that I've seen you write about before, like disability risk, pain, rib hump, and quality of life. How does this first discussion go?
I think the first discussion, especially for sure, like I mentioned right at the outset, is that it's getting people to understand that scoliosis is more than just the curve. Because everybody coming in, all parents, really have been operating under the premise that the curve is the entire condition, because that's how it's looked at conventionally. And so that's shift number one. And then once we go into that, then it's easy to see, because most people also know, okay, I have a family history, so I understand that, genetics can play a part. Maybe they just never really got all of the information as to how they can play a part, but they do. And then sometimes it's just starting off with the genomic testing to say, look, before we get any deeper into this, let's at least do the genomic testing, see where your son or daughter is at. We'll go through the results of that testing. And then if that shows up a lot of, caution flags, now we can do a lot of downstream testing just to kind of follow up. You just have to take some people where they're at.
Yeah.
Other people are just ready to dive right in and, do everything full tilt. And some of it depends on what kind of information they had coming in. So like in my practice, I do a free x-ray review with everybody. And by the time I get to that x-ray review, once it's, because usually from the time they schedule it to the time I'm on the phone with them is probably a good, 2 weeks or a month, something like that. And by the time I get to the phone call with them, they're already like researching like mad as far as scoliosis stuff goes. And they're trying to soak up all of this information. Really, the only question I really have to answer the most often is, well, how come her orthopedic surgeon never told us anything about any of this stuff? And it's like, you have to understand, an orthopedic surgeon is trained with a very singular focus. They're really looking at your child and saying, is this person a candidate for surgery or not at the end of the day? If they're not, are they bad enough that I need to do something else in the interim, like wear a hard brace? Or am I just going to literally do nothing and observe them, until such time as they either, are full grown or their curve now progresses to a point where now I would recommend surgery. Other than that, they're not going to do anything because that's just how the standard of care is laid out for this particular problem. And an orthopedic surgeon isn't going to care about what her progesterone looks like or what her genomics are or what her bone density looks like because that's not what they're dealing with. So, and, at least here in the States and in many parts of the world, conventional medicine is very compartmentalized. So I'm not surprised that they say that because again, everybody is still a product of their training at the end of the day.
We talked a little bit about setting up this disciplined schedule, right? An hour, some sort of lifestyle activities at home as the intervention, as part of the intervention. Well, tell me about what this kind of group of interventions or most effective interventions might actually look like for an adolescent having to do some daily work.
Sure. So again, I try to operate under the premise of do a little, a lot. And I think at the end of the day, that's the easiest way to make it a habit, right? I sort of joke to people, I say, look, the reason why everybody's good about brushing their teeth and yet nobody is good about exercising is just based on dose scheduling. People will brush their teeth 2 to 3 minutes a day, once or twice a day, far more regularly than they'll go up to the gym for an hour 3 days a week.
Right.
And by doing a little, a lot, it's easier to make it habit. It's easier for your brain to sort of put that habit on autopilot and then just continue with it almost without thinking of it. If I now have to break up my weekly routine by adding something in that I'm not necessarily used to doing, the chance that I'm going to keep doing it is very low by comparison. So whenever we set up exercise programs, some cases it's also dependent on the patient's age. So if I have, for example, I had one in here this morning. I have a 7-year-old that I was working with this morning. Obviously, I have to bear in mind that I am also dealing with a 7-year-old's attention span. So I have probably at most 7 to 10 minutes a day of her active engagement in terms of her being able to attain or pay attention and focus on what I want her to do before it's just going to go out the window. So her routine is going to be things that I can squeeze in that are very focused on her curve pattern, things that, from a neurodevelopmental perspective, she's able to do and have to do them at times of the day where mom or dad are at home. So they can obviously be over her watching, making sure that her form looks good and so forth. Now, as that 7-year-old becomes 13-year-old or 12-year-old, now we can sort of put a little bit more on their plate. And maybe now they're doing maybe 20 to 30 minutes a day of exercises that are, again, still very scoliosis specific, but maybe they're a little bit more complex than maybe what that 7-year-old was doing. And just in terms of the movements or the form of it or the difficulty of some of the exercises. And we just scale it from there. And then adults on the other end of the spectrum, again, it seems like the older we get, the busier everybody gets. So again, we kind of go back down into saying, okay, what can I give you to do that is either something that allows you to dual task, or if it doesn't, it only takes a few minutes a day to do. So like in my practice, for example, I created something called a scoliosis activity suit. I have patients across the board wear it, but particularly in adult patients with the demands on their time, they can literally put a suit on, go about their day-to-day business around even just their household. And now everything they do while wearing that suit also becomes a scoliosis exercise. And so the suit's essentially kind of like a neurofeedback device. And so whether, if it's a mom wearing the suit, maybe she's cleaning the house, maybe she's walking the dog, cooking dinner, eating dinner, whatever the case may be. If it's an older teenager, for example, they're just, doing around the house stuff, doing daily chores in it, whatever that might look like. And we just build it into what they're already doing. That way they're more likely to hang with it.
Wow. Awesome. I love it. That's so great. So would you say it's a combination of exercise and supplement therapy?
Yeah, and different lifestyle things. Anytime we see a lot of the hormone problems that we see very typically in scoliosis patients, we do a lot of education on, hormone disrupting chemicals in the environment, where you get exposure from those things, different xenoestrogens, stuff like that. So we do a lot of education on that from a lifestyle perspective. And then also we do a lot of things. So, as an example with neurotransmitter treatment, classically, usually that's supplementation, but we try to do a lot of other things also because, again, if I'm supplementing neurotransmitters through taking, amino acid precursors or whatever the case may be, even if by retesting urinary neurotransmitters to show that that supplementation is providing a benefit, what I don't necessarily know 100% is how much of that is actually getting into the central nervous system and doing its thing, right? So we then try to explore a lot of means of stimulating areas of the brain to produce more of those neurotransmitters intrinsically, whether that be with color therapy, or even now we're using biophotomodulation with laser therapy, and doing cranial applications of laser therapy and things. So
Cool.
things that we know are going to have more of a central impact. But again, it's just too hard to measure those things. But you can still see from an outcome perspective clinically, even in how in terms of impacts the endurance that they have with certain exercises and things like that, and their ability to retain a lot of different muscle memory patterns. It's having an impact on neurotransmitter metabolism that really has the biggest impact on whether or not those exercises become successful or not.
Right. Yeah. What's the follow-up schedule like in the tracking? Obviously you're tracking angle, but what else are you tracking and how frequently?
Well, we try to track a lot of visual metrics. So we'll do like digital posture photography, rib hump assessments, obviously the curve. We track with patient height. We track with different self-rated questionnaires, and not just in terms of pain and quality of life, but also even in terms of neurotransmitter assessment symptoms, hormone symptoms, digestive symptoms. I mean, we want all of those things to improve. Because when I'm looking at it and the way I'm explaining it to our patients is that, this curvature that we're seeing on the X-ray is no different of a symptom of scoliosis than your anxiety is. So if I want to see how well you're winning the battle against scoliosis, I need to look at how everything is changing, not just this curvature on the X-ray. Now, again, I realize that because everybody was trained, by orthopedic surgery from the outset, I have to still track their outcomes, which I obviously want to see improve. But it's just we're tracking obviously a lot more than that. And again, I get that when children are young, they're coming in here at say 12, 13 years old, because that number is what's determining scoliosis surgery, potentially on the horizon. That number is what most attention is paid to. However, what I also explain to parents about is, look, at some point, 12-year-old Sally is going to wake up one day and be 20-year-old Sally. And now, when she's 20, she's not going to care what she looks like on an X-ray. She's going to care what she looks like in a bathing suit or a wedding dress or a prom dress and all these kinds of things. The visible cosmetic impacts of it are going to be far more important to her than the X-ray curve measurement. And that, the outcome priorities evolve over the course of time. And then, of course, they wake up one day and they're my age, and now I don't care what I look like in an X-ray, and I don't care what I look like in a bathing suit. I just want to not hurt, and I want to be able to play with my kids or my grandkids and not pay for it.
Yeah. Wow. I feel like you've got this excellent structure happening, and obviously you've been incredibly successful. For our clinicians watching who are building their careers and determining how they can provide this level of service to a population, any population, can you comment on the type of practice you have? I know that you do boot camps, or there's a stream of sessions that happen. Everyone's playing around right now with different models of care. Can you teach us about your model of care and give us some opinion about what you think of it?
From the boot camp perspective, or whatever you want to call that kind of jumpstart process that we use, there are a lot of different non-surgical scoliosis methodologies out there that use some type of a similar jumpstart kind of a concept. Whether they call it, intensive therapy or inpatient rehabilitation, whatever it is, they're usually doing some type of, 1 or a 2 week kind of a program up front that's a little bit more intensive on the, clinic heavy, let's say.
Yeah.
But at some point down the line, you still have to have follow-up. So like in my case, once that initial intensive therapy has been completed, we are making an effort to follow up with patients every 3 to 4 months. And then usually what we do is we kind of alternate between doing a Zoom exercise update, for example, to where I can see them on camera, watch them do their stuff at home, and determine if everything looks good or if I need to make any changes. And of course, then the visit after that, so essentially in 6-month intervals, we're then also repeating their scoliosis x-ray study to see how well their curve measurements are doing, see if we're getting improvement or if the curves are remaining stable. And some of those goals will also be dependent on where they're at in their phase of growth. Because there are going to be times where if we know they're in a certain window of growth, around the first menstrual period, really the name of the game is to just keep the curve stable, because that's where curves normally explode, is around the first menstrual period. So if we can keep it stable through that, we're way ahead of the game from that point. And then as the child gets nearer to the end of, or closer to skeletal maturity, we then sort of back off those intermediate 3-month follow-ups and just do 6 months. And more importantly, continue to track them for at least 2 years past the point that they are done growing. And then in that 2-year process, after they're done growing, we might start, weaning down what their home exercise schedule looks like. And depending on what their end of skeletal maturity scoliosis x-ray measurement looks like, that determines for us what does the long-term maintenance of this look like if necessary. And the reason for that is very basic. I mean, in skeletally mature patients who have a curve greater than 30 degrees, if they do nothing to prevent it, that curve has typically about a 70% chance of increasing by about a degree per year. And so if that's the case, then we will recommend a very specific home exercise program to use as maintenance. If their curves are under 30 degrees, that risk is much, much less of that happening. So we're more likely to purely attack it from some of the genetic predisposition that they might still have. Like, let's say, for example, just MTHFR. Yes, at that point, I'm not as worried about MTHFR's impact on the curve anymore. But like I tell them, look, these things don't just go away because you became an adult. And now all of a sudden, I have to worry about the colorectal impacts of MTHFR. I have to worry about the B vitamin metabolism problems of MTHFR and the phase 2 liver detoxification problems of MTHFR. And these things are very real and will impact all aspects of your health. So to me, then, it's about sort of switching gears away from the curve entirely in that regard and focusing purely on a lot of the drivers of these things and drivers of other potential health problems later on to become more preventive in nature.
Love it. Yeah, I can see like clinicians watching who maybe work in other realms or, who are niched as well. I can see the value in just hearing your process and how well structured it is, but also personalized. The algorithm that you have seems to be not only effective, but so well laid out. I love it. So I'm really grateful to have spoken to you today, Dr. Morningstar. I think it's going to be so valuable for people to hear this. Can you tell us, where can people learn more about you and find out about your practice?
My main clinic website is just scoliosispractice.com. Very, very easy to remember. And then the company where I use to work with other doctors who are trying to do all of the same things that I'm doing is actually backgenius.com.
Backgenius.com. Very cool.
Yep. Thank you.
I really appreciate your time today. I learned a lot about scoliosis, but also your application of the holistic approach is just really, really excellent. So thanks so much for coming on Personalized and sharing your approach.
Thank you. No, like I said, thank you very much for having me. I'm very appreciative.
I'm just thinking about all the kids, who have benefited from your approach and how great that must feel, not only for them, but for you as a clinician. In my practice, it's trying to work in many different realms. Every day is a little different. And I find that exciting, but also lacking structure. Trying to build this kind of rhythm that you have around many different conditions can be very challenging and harder to track outcomes. And I just love the way that you've laid it out. And I think you've inspired me to kind of hone in on some of the things that I'm really passionate about too. So thank you so much.
Thank you for having me on.
We'll talk again soon, Dr. Morningstar. And I look forward to seeing you again in the future, maybe meeting in person one day.
I would love that. Absolutely. Thank you.
Talk soon. See you.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Duizer and at VitaminLab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.